concerned. So good afternoon all and welcome to another session of Neuro Ophthalmology. After that very good session of basics of neuro ophthalmology, now we move ahead to a little advanced session where we look into various clinical entities in neuro ophthalmology. And I am lucky to have, many distinguished neuro-ophthalmologists of the country as part of this instruction course. Many of them have not joined. Professor Pradeep Sharma, who was part of RP Center till recently as a head of strabismus and neuro-ophthalmology services. Professor Rohit Saxena, who is the current head of neuro-ophthalmology services and also member secretary of INOS as a part of this IC. We will soon have Dr. Satya also, who is a well-known neuro-ophthalmologist in the country and also a joint secretary of Indian Neuro-Ophthalmology Society. We have Dr. Paromita and Dr. Digvijay joining us for this IC. Dr. Paromita is assistant professor at GNEC Eye Center, New Delhi, and Dr. Digvijay is a director of Noble Eye Care. But it is my pleasure to invite and introduce Dr. Wang. We are lucky enough to have him in this session as a keynote speaker. And the topic of his talk is anisocoria, pharmacological or pathological. So I'll just share my screen to introduce him for this session. So just to introduce that, Dr. Wang is a very well-known strabismus surgeon and neuro-ophthalmology from Taiwan. He has completed his graduation and post-graduation from Taipei Medical University and has also holds a PhD in fields of neurobiology. Currently, he is director of neuro-ophthalmology and strabismus section, Department of Ophthalmology, Taipei Veterans General Hospital. He is also a council member for various ophthalmology society, including Asian Neuro-Ophthalmology Society, and also serves as a general secretary for the same. He has many publications to his credit and has authored a book called as Emergency Neuro-Ophthalmology, which contains various cases that may present in emergency and can be a life-saving if diagnosed on time. Over to you, Dr. Van. Welcome to India. I hope you are virtually enjoying the AIOS conference.
Thank you, Swati. Thank you for your kind introduction.
I'll stop sharing my slide and probably you may start sharing yours.
So am I going to speak first? Or who is going to?
Yes, we are supposed to start with your keynote address.
Okay.
Yeah.
Please start, sir. We can see your slides.
Okay. Dear Chairman and dear my friends in India, and I want to thank the organizing committee for inviting me to join the AIOS 2021. And I have no financial interest to disclose. Today, I'm going to talk about is this an anisocoria pathological or pharmacological? As you can see that this is a diagnostic flow chart modified from Dr. Alexandridis, and he has been separated into three parts. And the first one will be the larger and reactive pupil, and which will be focused on using some pillow cupping test. And the second part will be the smaller and reactive pupil that will be we should consider about chronic AD's pupil. And for the third part will be the pupils who shows normal response. And And in this category, we would think about the simple anisocoria and also the Horner syndrome. And today we are going to focus on the larger and reactive pupil. Let's look at the first case. That would be a 20-year-old male patient, and he had headache and nausea, vomiting for 1 year, and which is relieved after rest. It occurs with increasing frequency recently, and he denied diplopia. He was referred from the neurosurgeon for the evaluation of an isocoria. And as you can see that his vision was good, and his EOM was full, except for a minimal limitation of A deduction in the left eye. However, he have a fully dilated pupil in the left side, and which does not respond to 0.1% of pilocarpine after 40 minutes. And then we use 2% of pilocarpine test. It constricts to partially to 6.5 millimeters. And the MRI show a 2.1 centimeter soft tissue lesion over the left paracellular region. And the differential diagnosis include arachnoid cyst or cystic neurogenic tumor. Surgical intervention has been suggested, but the family decided to observe. And he has been followed up for 5 years, and his anisocoria and the paracellular lesion remain stable. So cerebral palsy may present as an isolated mydriasis in arachnoid cyst. Dr. Herster has reported isolated unilateral mydriasis with delayed onset oculomotor nerve palsy secondary to arachnoid cyst. And Dr. Ashker also reported an 8-month-old boy present with an isocoria and with cholinergic supersensitivity as the only sign. Ductal deficit and ptosis were absent. 19 months later, he had developed an concomitant axial deviation with supraduction deficit. Brain MRI revealed the arachnoid cyst compressing the third cranial nerve in the right interpeduncular cisterna. So 1% pilocarpine may also exist in dorsal midbrain syndrome and also cerebral palsy. It is presumed that transsynaptic neuronal cell death may be the underlying pathogenesis for the cholinergic supersensitivity in the cerebral palsy. So in this case, we learned that cerebral palsy may also present as an isolated anisocoria without the clinical manifestation of EOM limitation or ptosis. Cholinergic supersensitivity exists not only in AD's pupil, may also occur in cerebral palsy, dorsal midbrain syndrome, Miller fissure, and migraine. Let's look at the second case. The second case is a 38-year-old female patient, and she complained about blurred vision, especially for the near target with photophobia, and she visited municipal hospital in June 2016. The vision was good, however, her left pupil was dilated. She admitted that she had helped her son to take eye drops for myopia control. And her fundus and OCT scan was normal. In August, she returned to the municipal hospital again and said that the dilated left pupil resolved spontaneously 1 month later. The same condition occurred in the right eye. She was absolutely sure that she did not touch the myopia control eye drop for her son recently. As you can see, her intraocular movement was full, and she was referred to our hospital with CD copy of MRI. She visited our clinic on September 26, and the vision was good, and you can see that right pupil was mid-dilated to 4.5 millimeters. And the dilated pupil does not respond to 0.1% pilocarpine after 40 minutes. Then we use 1% of pilocarpine. It constricts partially to 3.0 millimeters. And her MRI showed there is a lesion over the interpeduncular region at midbrain level on T1 weighted image. differential diagnosis include lipoma or dermoid cyst. And we look into this MRI in more detail. The upper row is the T1 weighted image, and the middle row is the 3D Viesta, and the lower row is the time of flight. And on your left-hand side, that would be the upper level of the midbrain. You can see the optic chiasm over this region. And at the middle row, that would be the middle part, and you can see the pituitary stalk. On your right-hand side, that would be the lower level of the midbrain, and then you can see the carotid siphon over here. And the lipoma is located over the upper and the middle level of the midbrain, which is hyper-intense on T1 weighted image and heterogeneous intensity on the 3D Viesta. On this middle level, you can see the lipoma is associated with a linear structure over here, which is hypo-intense on T1 weighted image and hyper-intense on the time of flight, and which indicate this could be a vessel. And from its direction, we think that should be a PCOM and artery over here. And on the lower level of the midbrain, you can see the lipoma is not seen over this level. And you still see two linear structure over here, which is iso-intense on T1 weighted image and also iso-intense on the time of flight, which indicate it should be a nerve tissue. And we presume this two linear structure is the oculomotor nerve. On this cartoon, we can see that the oculomotor nerve will exit from the midbrain between the PCA and the superior cerebellar artery. And we know that PCOM artery will connecting with the PCA over here. And so the PCOM artery should be superior to the oculomotor nerve over here. And the lesion is about at the level above or at the level of the PCOM artery over here. So we think that the lesion may not be comprising the oculomotor nerve in this case. So we decide to observe this patient. And the patient came back 1 month later at October 17, and she reported that the right pupil returned to normal size in early October. However, 3 days before she visited us, she felt itchy on the right eye and used flucloxone and armitol eye drops. She found her right pupil dilated about 3 minutes after the eye drops. Armitol eye drop is composed of two components. One is the anatazolin, which is an antihistamine, and the other one will be the tetrahydrozoline, which is an alpha-2 agonist used as a sympathomimetic decongestant, and has been reported to be associated with pupil dilatation. After substituting the anti-allergic drugs, she did not have any further attack of mydriasis afterwards for a 2-year follow-up. The interpeduncular lipoma has been followed by MRI for over 2 years, which has remained the same, very stable condition. So in conclusion, even pharmacologists, mydriasis may respond to 1% pilocarpine partially, and the pilocarpine test, either diluted or not, should be interpreted cautiously. And the neuroimaging study provides a high spatial resolution and help for the differential diagnosis in this condition. Thank you for your attention.
Thank you, Dr. Wang. That was a wonderful case of interpedicular lipoma. Thank you for being here, joining us. Right.
Sure.
So as we take forward this this IC, I think Dr. Rohit is yet to join us. I'm not sure if he has joined or not. So
we could start with your presentation, and then when
yeah, that's what I feel. So I would
start.
rather start with my own presentation on idiopathic intracranial hypertension. I will be talking about a small study that we conducted at our center. Are my slides visible?
Yes, ma'am, it is visible.
Okay. So I would be talking mainly about the a study that we had conducted at our center on the OCT parameters of IH, but before that a brief introduction on IH. So IH is a condition that is characterized by raised intracranial pressure for which no particular cause can be determined. Obesity is considered as one of the major risk factor because one of the reasons that the weight reduction is associated with the early resolution of symptoms in cases of IH. Systemic disease and endocrinal abnormalities are also risk factors. Medications like tetracycline, vitamin A analogs, and oral contraceptives may also precipitate the disease. The clinical features include headache, which is generally associated with nausea and vomiting and get worse in the morning. Diplopia is due to the sixth nerve palsy, which gets compressed against the petrous ligament due to raised intracranial pressure. Pulsatile tinnitus may be an early symptom and is quite frequently seen in these cases. Paplidema indeed is the characteristic sign, and the major morbidity of the disease is visual impairment. Around 40% of patients may show some kind of visual disability in these cases. So the diagnosis of IIH is according to the modified Dandy's criteria, which includes the signs and symptoms of IIH along with the normal neurological examination and normal imaging without any evidence of cortical venous stenosis and raised intracranial pressure of more than 250 mm. Friedman actually tried to categorize these diagnostic criteria on the basis of presence or absence of papilledema, where he said that in the absence of papilledema, if all other signs and symptoms are present, then the presence of sixth nerve palsy itself may be enough to diagnose a case of IIH. There are certain subtle signs on MRI which may raise the suspicion of IIH in absence of papilledema, and they include empty sella, flattening of posterior aspect of the globe, distension of the optic nerve sheath, and transverse sinus stenosis are the common signs that are seen in MRI. So the main goal of management is preservation of vision and relief of headache. So we have to first remove whatever is the precipitating condition. There is factors that that are responsible for development of this IIH. Weight loss is now considered as an important part of the medical management. Then there are drugs as well as surgical management. There are various studies which have shown that weight loss of around 6 to 10% may lead to early resolution of papilledema. So a lot of neuro-ophthalmologists advocate weight loss, and patients are encouraged to, maintain their weight so that the recurrence of the disease doesn't happen. Idiopathic intracranial treatment trial was one multicentric randomized double-blind treatment trial that compared acetazolamide to placebo, and they found that the patients on acetazolamide had greater improvement in mean deviation, significant improvement in mean grade of papilledema, and at the same time acetazolamide may also augment the weight loss, that thus helping in the resolution of the disease. The other drug that is frequently used in IIH is topiramate, which is basically an anti-migraine drug and is also causes suppression of appetite, aiding in weight loss again. So these are the drugs that are commonly used in IIH, and idiopathic intracranial hypertension treatment trial kind of established the role of acetazolamide in this condition. The surgical management should be reserved for the patients who do not respond even with the maximum medical therapy. So, and also for the patients who have very acute and fulminating presentation where there's a visual field loss or the visual acuity is very, very poor at the time of the presentation. So in these cases, if we just do a medical management, that may not be enough to preserve the vision. So we have three surgical options with us as far as the IH is concerned: the optic nerve sheath fenestration, shunting surgeries, and stenting of the venous sinus. So there is a general consensus that if one has more prominent visual symptoms, it is better to do an optic nerve sheath fenestration. And if one has more neurological symptoms, particularly headaches, doing a shunting procedure may be a good idea. The venous stenting should be reserved to the cases who do not respond to the maximum medical therapy and also at the same time show the presence of venous sinus stenosis. However, it should be kept in mind that all these procedures have a temporary effect and there are very, very high chances of them being, blocked again, closed again, and recurrence of the disease. So these patients should be encouraged to have some weight loss so that the resolution is maintained. The role of OCT in this condition is now being, gaining importance in our day-to-day practice. Not only it helps in differentiating a true papilledema from pseudo-papilledema, particularly drusen, it also helps in monitoring the progression of the disease. At the same time, it also helps in determining the cause of loss of vision in these cases, which may be seen in form of thinning of GCL layer or macular changes or choroidal changes, which may be the cause of loss of vision. So we tried to conduct, we conducted a study in which we tried to see the changes, OCT changes prospectively in the patients of IH over a period of 6 months. And we tried to find out how these changes occur. At the same time, we also tried to evaluate the effect of weight loss on these OCT parameters. So patients after demographic details and other clinical details, the visual acuity and visual fields were recorded and so was OCT. We did 3 scans for OCT parameters, the optic disc scan for peripapillary RNFL thickness, macular scan for GCL IPL thickness, and a 5-line raster scan on the disc which was used to measure the disc height. So this just gives us the height of the edema, the elevation of the disc, which can be used as a clinical parameter to follow up the patient. All the patients received oral acetazolamide as per their weight and requirement, and all patients were particularly counseled for the weight loss with the help of proper diet chart that was formulated by an expert dietitian and were encouraged to do exercises. So as we followed up these patients, we had seen that the optic disc height gradually decreases over the time as the edema resolves, which was pretty obvious that it tends to decrease. Similarly, we also found that over the time, the RNFL edema also decreased. If you can see here at the time of presentation, it was markedly raised and it decreased to certain extent and almost came to the normal level at the end of 6 months. But interestingly, what we found that GCL had shown thinning at the time of the presentation, but had also shown some improvement at at the first follow, which is at 6 weeks. So you can see at this point of time at the presentation, the GCL thickness was there, but there was an improvement at the after the 6 weeks follow up. So around 30% of patients had low GCL IPL thickness at the end of the follow up, and around 25% had normal GCL thickness at this follow up, but these patients still had increased RNFL. The final visual acuity and mean deviation correlated better with optic disc height and GCL IPL thickness rather than RNFL thickness. For the effect of the weight loss, we found that the improvement of visual acuity and mean deviation correlated better with the change in mean deviation for the patients who had more weight loss as compared to patients who did not. And also the disc height showed more improvement or had more correlation with the patients who showed change in their BMI. Similarly, the patients who showed complete resolution of papilledema had more weight loss as compared to patients who did not. So to conclude that, I would say weight reduction should be an integral part of the management of the IH for better outcome. And GCL IPL thickness should be interpreted with caution in presence of severe disc edema, and otherwise, if in cases of disc edema, because of the segmentation error, which is due to inbuilt software of the machine, the GCL IPL layer may come as falsely thin, and we may think that this patient has poor GCL IPL layer thickness. Similarly, for the better outcome predictors were GCL, IPL thickness layer and optic disc height, we should rely on them more rather than RNFL, because it has been seen that over the time, the GCL IPL thickness gradually comes down, but the RNFL edema still persists. So it should not give us a false sense of security that patient is getting better because the RNFL edema is decreasing. We should actually also look for the GCL IPL layer thickness, where if we have thin GCL, we should consider that the patient is probably progressing. Thank you. So I now invite Dr. Digvijay. I'm not sure whether he has joined or not, but we do have Dr. Satya, who is a prominent neuro-ophthalmologist of the country and also a joint secretary for the Indian Neuro-Ophthalmology Society. So over to you, Dr. Satya. You may please start sharing your screen.
Hello, Swati. How are you?
I'm fine. Thank you. Good to have you here. Thank you for joining.
I just had a question. It's just out of curiosity. Do you think that all middle-aged obese persons should undergo fundus examination as a routine?
Fundus examination, not, particularly if they are female and having some visual complaint, yes, they should. But may not be all of them.
Yeah, because now that we have OCT, if it's an early disc edema and patient is asymptomatic, usually these patients are asymptomatic in terms of, vision, but they may have had blackouts, they've not been thinking or noticing it and not complaining about it, isn't it?
Right. So transient visual obscuration, yes, is one of a very early symptom of Paplidema. So those patients definitely require examination of fundus. Yes.
Yesterday, there was a very interesting paper in the free paper session, which said from Bombay that they are studying on the fundus photo and the features of disc edema, papilledema, basically using artificial intelligence and Wolfram language. It is a software to study images. So their parameters were different from what we've been using in usual fundus examination and OCT and other studies. That sounded very interesting. It is Dr. Sunil Morekar, I think he's doing it.
Yeah. I have heard them once in last AIOS also. They had presented a similar kind of paper.
Okay.
So yes, it is very interesting because they are kind of developing an algorithm with the clinical photograph, OCT, and probably clinical features. They're trying to put them together and develop an algorithm to monitor, to diagnose and monitor this disease.
Yes. And
But
yesterday's paper was about prognostic value.
Okay.
Planning to accumulate all the data, 291 eyes of papilledema.
Oh my God, that's a huge number.
Huge number.
Yeah.
And they're going to come out, they've not yet finalized it. They'll come out with the results and probably it'll be very useful to have that in practice.
Yes. If we can have that kind of algorithm, probably for the general ophthalmologist, it may be quite useful to have that. Yeah.
Good.
Yeah. Thank you. So we can now have your talk because I think other speakers are yet to join. So
Digvijay is here.
Yeah, I'm here in case.
okay, yeah, good to have you back, Digvijay. I hope all your other commitments are over now.
So just finished that and I just joined in.
You're hopping from one hall to other.
I know. Easier with a click than to run in a big conference venue, I suppose.
Yes, indeed, that's a boon for of the virtual conference, I would say. Right. So we have Dr. Digvijay here, who is the director of Noble Eye Care and also a treasurer for Indian Neuro-Ophthalmology Society. He would be talking about ischemic optic neuropathy, non-arthritic one, and the latest update in that disease. So thank you, Digvijay, for joining me. Over to you now.
Yes. Thank you. Let me just shift to my presentation. All right. Is my presentation visible?
No, sir. We have some Zoom link coming here.
Okay, wait. Zoom link. Let me just stop sharing and reshare. Just one second. So there now?
It is now, sir.
Okay, okay. Thank Dr. Swati for giving me the opportunity to be part of this instruction course, and we take on from what is new in neuro-ophthalmology and something that all of us should be aware of. I'm going to talk about a disease, a common condition called ischemic optic neuropathy, a condition which has been getting a lot of attention of late because there has been some work going on in this. Unfortunately, in the past there wasn't much that one could achieve in these cases, but now with our understanding increasing, there are some breakthroughs that have happened. So briefly, I'm going to talk about NAION, and that's the subject that I've had. So ischemic optic neuropathy is the bigger topic, and then within that we have non-arthritic anterior ischemic optic neuropathy, or NAION, and that's what we're going to talk about in today, an update on what's happening in that field. So NAION is a more common form of ischemic optic neuropathy. It's much more common in arthritic. So it's majority of the ischemic neuropathy is basically the non-arthritic phenomena. It presents in the 6th to 7th decade. It is because of obscuration of the short posterior ciliary arteries that happen, and the risk factors for this could be a small optic nerve head, which are the ocular risk factors or the disc crowding. Then there are systemic risk factors, which could basically range from hypertension, diabetes, collagen vascular diseases, cardiac diseases, so homocystinemia. So a lot of these coagulopathies. So anything which can lead to some kind of a vascular compromise, a blood supply compromise to the optic nerve, can lead to an ischemic optic neuropathy. And this presents with a sudden painless vision loss. Typically, people describe it on waking up in the morning time because there has been some nocturnal hypotension, and this presents with a few features, typical clinical features such as an altitudinal field defect, as well as it can present with an RAPD. And you'll get to see a disc which is having a segmental kind of a disc edema that could be initially hyperemic, then going into a pallor as well. And again, it's a small, the fellow eye would have a small crowded disc that you could look at. There could be some peripapillary hemorrhages. The fields I've already discussed would have an altitudinal kind of a field defect most commonly, but you could have a generalized depression, a constriction, different kinds of field defects are possible. Color vision contrast is usually affected in these conditions. And then the risk of involvement of the other eye is about 15%, or 5-year risk of involvement. So that's why it's important for us to take care of any risk factors which are, which could be causing this, any kind of a systemic risk factor. One thing that differentiates this kind of an edema, ischemic neuropathy, from optic neuritis is that the disc chromatoxia is not as severe as the case of optic neuritis, and this is happening a little bit more in the elderly people. And we're knowing that as such, there is no definitive treatment as of now. Control of risk factors, some people have tried aspirin, there is anecdotal evidence there on that front. But steroids have also been tried of late, and we'll come to some of the updates on that front. Now, this is what it looks like, the clinical picture. You can see a slightly edematous disc. The other disc is looking small at wrist. You can see slightly tortuous vessels, and there is leakage on the fundus angiography. So what is changed? What is happening, changing in what's new in the understanding of NAION in the last year or so? So one, that with the use of the OCT angiography, we've seen that there is a definite difference in the perfusion in the small vessels that are present in the peripapillary area, or the superficial capillary plexus there, as well as the superficial and deep capillary plexus in the macular area. So this both has been said. So we know that there is a small vessel disease that's happening. It's not really necessarily a large vessel disease up front. Apart from that, we are also realizing that one of the factors definitely we look at was inflammatory changes in ESR CRP for the arthritic area. But now for NAION, a red cell dystrophin width is a factor which is shown to have an association in up to about 33% cases, or a strength of 33%. And again, as of now, we don't yet know the implications. This has just been coming out, and people have found that there is an association with erythropoietin levels as well in the past. But so our understanding of pathogenesis is not just a stroke. Actually, there is an inflammatory component. There is a compartment syndrome that forms, and there is some edema that develops even on the macula. Now, what is happening in terms of what is new in terms of NAION treatment? So let's look at steroids, and I think that's something that we've been discussing as well quite frequently in the past. While there is no definitive evidence to say, there's no randomized control study which is saying that steroids are the ones which go in this way, but we have found that it's definitely required for arthritic AION, but for NAION also in non-diabetics, it may be useful. And there's an randomized control trial that we had conducted with Dr. Rohit Saxena, Dr. Swati, all of us at RP Center. We found that there was a 2 or more lines in the non-diabetics compared to a placebo, and that you needed to treat 4.7 patients in order to see a visual acuity 2-line improvement in one eye. So there could be a possible role of a steroid in NAION. On the outcome, there have been various studies which have looked at steroids. as far back as the 1970s by Folds et al. And a big proponent of the steroids has been Dr. Harry, SS Harry et al. And his studies, including a patient choice study in the past, has found significant benefit based on steroids. So, but I'm not going to go into the details of these, but these are easily available. And you can see just by this table that how many studies have been there. And as many studies as have said that steroids are beneficial as this group, the similar number have also said it doesn't really have a benefit, and they find no benefit out of use of steroids. So therefore, this still continues to be a gray area. There have been adverse effects of steroids that have been reported in various studies, and we should be aware of that. And these include development of serious adverse effects in about 30% of the patients, and 10% would need an increase in diabetic medicine. The sugars will permanently go up. But overall, we've seen that, at 20 and different studies by our study as well, that 25% of patients on steroids developed some side effects as compared to 13% of placebos. So there is definitely an impact. So one has to be careful in how to use. And impaired glucose tolerance is one of the major things that you could see. There was a study going on recently about a small interfering RNA called QP11007. It was a novel agent that was thought to prevent cell apoptosis. Unfortunately, not too much benefit was observed in the phase 2 studies from this. A few studies have now have happened on certain other compounds as well, one of which is the ROCK inhibitors. So they've looked at that. So they've seen that these ROCK inhibitors, which have now been also being Rho kinase inhibitors, which are also being used in glaucoma practice, have reduced the retinal ganglion cell loss, by having a strong antioxidative effect as well as anti-inflammatory effect, and even they prevent the disruption of the blood-retina barrier. So they found that this could possibly reduce the amount of damage that one could see, in cases of NAION. And this is again something that has just come up last year and been published this year. So while work is going on in NAION, in terms of its pathogenesis, its treatments, we still have to make a significant headway. As of now, control of systemic risk factors, use of things like aspirin, use of giving multivitamins, the only choice that we have. Another thing I want is COVID and NAION. And this is NAION has been something that people have had raised concerns about in the last era, ever since COVID came. But one from the vascular and thrombotic aspect, but more so from the fact that a lot of patients are put on prone positions, and it is in these proning positions that there is pressure on the eye, and there is possibly a theoretical risk of NAION. Though we haven't really come across anything other than probably one report on the same. So, but just to sensitize that NAION is something in the COVID period that people are have reported, but not so much from a prone position, which was initially theoretically thought so, more from a vascular thrombotic standpoint. So I thank you for this quick update on NAION, and happy to take any questions.
Yeah, thank you, Digvijay. That was indeed a very good update. I would say all recent things you have covered. You have also covered about, my question would be like, how do you consider whether you want to give steroid to this particular patients? What factors do you keep in your mind when you want to give steroids?
See, one of the things now that I look at is that the person should not have a systemic situation which is labile, which is likely to worsen because of steroids. If it's a labile diabetic, an uncontrolled diabetic, I wouldn't be thinking of giving steroids at all. It's going to only make the situation worse. But if somebody is not, if somebody has a significant disc edema, or if somebody has come to you with a very acute presentation, you could consider obviously under monitoring, because you can't just give it and let the sugars go haywire. That's going to worsen the situation. But in fact, I think you've been using it as well somewhat in RP center. How are you using it at the moment? Still oral, or are we doing IV steroids as well?
No, we are not kind of giving IV, at least oral, as you rightly said. In certain subset of patients we use, but I personally feel we can use it if we have young patients who do not have other comorbidities like diabetes and hypertension. So it may be quite useful in those young patients who are in their 40s. A lot of young patients are also coming up with now ischemic and so in those patients, maybe it is of use for some use. Dr. Satya, your thoughts on this?
I think I agree with both of you. Nothing different from your experience. I have a question for Digvijay here. That what about these ROCK inhibitors? Is there any recent study?
These are all in rat models. So the human studies have yet to prove any.
Okay.
At least the rats have some sort of treatment now.
Yeah. Before we could have it. So Thank you, Digvijay, for that interaction. And now I invite Dr. Paromita, who is Assistant Professor at Guru Nanak Eye Center, New Delhi, for her talk on toxic optic neuropathy. Over to you, Dr. Paromita.
Is my screen visible?
Yes, you are. Your screen is visible. Please go ahead.
Okay, good afternoon. Today I'll be talking about toxic optic neuropathy. Regardless of the underlying etiology, the visual dysfunction in optic neuropathies is generally characterized by loss of visual acuity, color vision dysfunction, and visual defect, such as central previous toxic in the form of medication or any other substance, prior surgery, family history, dietary habits, or any dietitian. Also, a review of symptoms should include sensory disturbances in the peripheries or peripheries, including gait problems, which might indicate a toxic peripheral optic neuropathy. The underlying mechanism of axonal and retinal ganglion cell injury in toxic metabolic and hereditary optic neuropathies is primarily the result of some degree of mitochondrial dysfunction. This dysfunction might be due to an exogenous like a toxin or a drug, or intrinsic cause like a genetic defect. Mitochondria are a major generator of reactive oxygen species and therefore a main target of oxidative damage. As proposed by Sadden and Wang, mitochondrial optic neuropathy seems to be an appropriate umbrella terminology under which these group of optic neuropathies can be grouped, and mitochondrial neuropathies. Injury to the papillomacular bundle results in the centrocecal visual field loss. The papillomacular bundle is particularly vulnerable to this type of insult because of its unmyelinated nature, requiring depolarization along the entire length of the axon, smaller caliber, and lesser amount of superoxide dismutase, owing to mitochondrial dysfunction. With drug accumulated with ethambutol toxicity, toxic neuropathy, ethambutol is the drug that comes first to our mind. So ethambutol is a metal chelator which inhibits mitochondrial wall synthesis. In mitochondria, iron and copper chelation results in disruption of complex 1, complex 4, and cytochrome C oxidase. It also increases oxidative damage. The total number of notified tuberculosis cases in India is around 21.5 lakhs according to the RNTCP report in 2019. The toxicity is dose dependent, with around 1% risk at 15 milligram per kg, and 20 milligram per kg would carry a risk of around 3%. Overall Indian incidence of ethambutol toxicity ranges between 0.6 to 3%. Now we probably have around 22 to 66,000 number of patients with ethambutol related visual impairment, and which is a very significant number, and it's a preventable cause of toxic optic neuropathy. Generally, this type of neuropathy arises within 2 to 8 months of starting therapy, but early idiosyncratic reactions have been reported, and dose adjustment is required in patients with renal dysfunction. Though many patients may not complain of any vision loss or color vision deficit, there may be subclinical toxicity detected by electrophysiological tests and OCT. Whether this is of visual significance or not is yet to be seen. Now, RNTCP has given new guidelines for tuberculosis treatment. According to this new regimen, the earlier 3 weekly regimen has been swapped for a daily treatment regimen, and ethambutol, which was earlier given only in the intensive phase, is given in the continuation phase as well. So instead of 2 months, now ethambutol is to be given for 6 to 9 months. However, the safety profile has been increased by providing weight bands. However, if you see carefully, this does not completely ensure a higher dose of ethambutol, that reaches up to 20 milligram per kg per day. And we have to be extra careful in patients with malnutrition, alcoholism, diabetes, hypertension. Coming to ethambutol toxic neuropathy in pediatric patients, the prevalence is supposed to be lower because of lower serum concentration of ethambutol for the same given dose. However, it is difficult to actually identify toxic optic neuropathy in preverbal children According to the new weight bands, children are actually getting close to 25 milligram per kg per careful monitoring of such patients. Ethambutol toxicity may also affect other regions, may exacerbate neuropathy, and nucleoside reverse transcriptase inhibitors, which are a part of the ethambutol via multiple hit effect. Since early diagnosis and the drug to managing this condition, a proper examination and monitoring has to be maintained, starting with baseline visual examination to be repeated at periodic intervals. Asymptomatic patients can be seen every 3 months. Anytime they develop symptoms, they have to be seen. A closer monitoring of patients with higher risk factors is advisable. So the management depends on time stopping of the drug. Drug continuous must result in irreversible visual loss. Zinc and supplementation. The treating physician can high-risk patients and report any adverse events like toxic ethambutol. Notification of confirmed cases of ethambutol-related optic neuropathy is very essential, and this is done with the IDP or Vigilance Program of India to give a better idea of the evidence of ethambutol of risk factor. Coming to drug, antibiotic which was used for drug-resistant enterococci and staphylococci, when used in conjunction with ethambutol, exacerbates its toxicity. Similarly, with chloramphenicol, again, dose-dependent and duration-dependent. Other drugs like fluoroquinolones, aminoglycosides, so toxic. Described to have a bilateral NAION-like picture, but this is different from the classical NAION in that it has an insidious onset. The of this and for and in 1 year of treatment, but some people have suspected that this may be a 2 NAION because patients who are on amiodarone also have this as those NAION. Phosphodiesterase inhibitors have also been likely labeled as causal in with the NAION. Nitric oxide induced response. TNF-alpha also associated with whether it is or say increased susceptibility to patients of the conditions TNF-alpha inhibitors are administered is debatable. Then tacrolimus used for organ transplants with NAION-like biology
Hello.
Picked up on OC, and this is advised as early screening which causes acute loss of vision associated with metabolic acidosis. Treatment depends on correction of metabolic acidosis and clearance of methanol and its metabolites. The Cuban epidemic was an example of a combined insult, both toxic and metabolic. And the earlier labeled tobacco alcohol misnomer, cases were probably LHON carriers or syphilitic optic neuropathy or had optic neuritis. It is probably an optic neuropathy of nutritional deficiency type. Now there is a genetic disposition system. Nucleoside transferase inhibitors have been reported to trigger visual loss in LHON carriers. Also, ethambutol can precipitate visual loss in LHON and dominant optic atrophy carriers or patients. And alcohol antibiotics may trigger the phenotypic expression in angels with LHON gene mutations. So this is a flowchart showing that toxic optic neuropathy is generally the last possible diagnosis, and it's a diagnosis of exclusion. Once you've ruled out all possible other etiologies. Treatment is stopping the drug as soon as possible. We have to be very thorough in our history and our investigations so as to prevent further visual loss, try to prevent further visual loss. Thank you.
Thank you, Dr. Paramita. That was indeed a comprehensive overview about toxic optic neuropathies. I just want to know if you have seen any increase in incidence of this this problem because of change in RNTP guidelines. Are you seeing more patients than?
No, honestly speaking, we have seen more of linosal associated optic neuropathies because we get a good number of these MDR and XDR TB patients. We have actually not looked into the changed regimen as a factor. We will definitely from.
Okay, thank you. Now we have Professor Pradeep Sharma with us, who was part of API Center till recently and is now with Center for Sight, heading their strabismus and neuro-ophthalmology services. It's quite a pleasure to have you, sir, here in this IC. And over to you for your talk. He would be talking about OCT, role of OCT in for day-to-day neuro-ophthalmology practice. Over to you, sir.
Thank you, Dr. Swati. It's a pleasure to be with you all once again. And I think 40 years back when we were doing residency, the question would have been whether imaging CT scan or MRI, is it mandatory? Because we were in an era when they were just coming and we were doing topographic localization using the visual fields in our brains. Now we are in the age in which OCT has come in a big way and it is helping us, the neuro-ophthalmologists. We need to discuss how and what. The role of OCT in neuro-ophthalmology, it's a very important thing to understand because it's non-invasive, non-contact technique that uses low coherence interferometry to obtain high resolution images, cross-sectional images in vivo of the anterior and the posterior segment of the eye. And in case of neuro-ophthalmology, we are concerned with the retina and the optic nerve. It has come through an evolution of the time domain OCT, then the spectral domain, then the enhanced depth imaging, the swept source imaging OCT, and then the OCT angiography, and now more recently the AO married with the OCT, the adaptive optics OCT, and of course the 3D imaging. We have come to understand the Alzheimer's, the Parkinson's diseases in a much better way because eye is the window to the brain. And conditions like papilledema can be easily differentiated in a non-invasive manner from pseudopapilledemas. Optic nerve lesions, whether they are the optic disc drusen's or the foams, the peripapillary reflective ovoid mass lesions or melanomas or benign melanocytomas, the optic neuropathies, ischemic, hereditary or toxic, compressive, infiltrative. In all, there is some role of optical coherence tomography. Recently, an overview on optical coherence tomography, I came across the Annals of Eye Science, and I would recommend everybody to read this beautiful review article. It describes the figure I have borrowed from there, and it shows how the evolution has happened from a fundus photography to the traditional color fundus, from that to the TD, the status domain, time domain one, and then to the spectralis, and then coming to the OCTA, and finally to the 3D imaging. The last one image is very dear to me because it's the three-dimensional reconstruction and it gives you a real live picture as if you're seeing. It further goes on to show in detail how the imaging of this is done. And in this figure C, you can see a drusen which is shown, and in the D, you can see a foams. As I said, this is the hyperreflective ovoid mass lesion, which is peripapillary. And so OCT in neuro-ophthalmology, it's a very helpful technique. We can see these conditions as I just mentioned. For the deeper structures, the enhanced depth imaging gives us the answers which are required. I'll just show you a case. Now, this case came to me with a sudden blackout. There was peripheral vision loss. He was the recipient kidney transplant, and he was hypertensive, but was well regulated according to him. He had a COVID about a month back, and he had recovered from it. He was on alfuzosin for his prostatic problem, and he had stopped the blood thinner just 4 days back. His vision was 6/6 in both eyes, but if you see the fundus, you'll see there was a appearance of a blurred disc margin and a pallid disc in this. So one would naturally clinically suspect, think the fields will show an inferior altitudinal defect in the right eye. You can see this. And if you see the OCT, it classically shows you, and then the comparison of the right and the left eye keeps the picture, everything clear on your in front of you. This is the advantage. It's very good for documentation, and the clarity with which it can define even the minor deficiencies is there. Even, for example, optic neuritis, this can be shown on the OCT very well, as this picture, which is again from a very nice article from Kerala Journal of Ophthalmology, which I would again recommend people to read. This is showing you in optic neuritis. Again, in toxic optic neuropathy, you can see the corroboration of the visual fields which are affected in both the eyes, and the correlation with the OCT is very nicely shown, how the segments are involved. Again, in the compressive optic neuropathy, one can see the change which is happening in the fields and the corroboration. In one eye, in this case, there was a total loss of field, and the other eye, there was a quadrantanopia. So it was like a junctional scotoma, and we can see the changes in the OCT very nicely corroborating with the fields that are there. The role of angiography, the OCT angiography, is now coming up. There is again a beautiful survey article by one of our colleagues, Dr. Amar Pujari, who has shown a review of all the OCT angiography which is there. So short of time, I may not go into the details, but I would recommend all of you to read this nice survey major review which is there. The OCTA is basically reconstructing the images, the motion sensitive contrast images, which are, so this is a sort of proxy for fluorescent angiography. It doesn't actually give you the leakage, but it will give you the vessels, and the motion is sensing by that, and we can get that. The role of OCT in papilledema is again an important thing that we need to remember. Traditionally, we know that the RNFL thickness is higher in both papilledema and the papillitis, and more so in the papilledema. But a study done by us in RP Center by Dr. Paniala showed that there is an interesting thing. If you do a cube on the optic nerve head, you can see the Brooks membrane RPE angle, which is in normal cases pointing away from the vitreous. So there is a minus 5.32 angle made in normal people. Now to compare this in papilledema, you'll find that the angle is reversed. It's a positive, and it may be much more in a more severe papilledema. It's up to plus 15. And this is something which is very interesting in papillitis. Interestingly, you will see that the RP Brooks membrane angle, although sometimes papillitis cases may be confusing as far as the picture is concerned, but the Brooks membrane and the RPE does not confuse you. It clearly shows you a normal presentation. Now we have the adaptive optics, which is now married to OCT, and it has improved the imaging properties of the OCT by using the adaptation of aberrometry cancellation. And as you can see in this picture, a simple picture on OCT taken, and then on the two sides you can see the AO OCT, which gives you a much more clear focus structure. We had done a study on the AO SLO, and on this, as you can see, we had done the Voronoi diagrams, and we have seen that the cone densities can be easily picked up. So to conclude, OCT role in neuro-ophthalmology is immense. In today's world, we need to use OCT not only for documentation and the prognostication and monitoring of cases, but also as a research tool in neurodegenerative diseases like Alzheimer's, Parkinson's, differentiating papilledema from pseudopapilledemas, optic nerve lesions like the optic disc drusen, which may sometimes confuse you with papilledema or the foams or the melanoma or the melanocytomas, optic neuropathies of all kinds. It will be helpful in knowing. And finally, just if you could dissociate your eyes and see this, you will have a reconstruction of a 3D picture. And this is a novel interactive display of OCTA. So thank you all for this. Thank you once again, Swati.
Thank you, sir. It was a pleasure to have you. And I think we can now move to our next talk. I'm not sure if Dr. Saxena has joined us or not. So we now move to Dr. Satya Khanna's talk on the imaging. Dr. Satya is the prominent neuro-ophthalmologist of the country and also the Joint Secretary of Indian Neuro-Ophthalmology Society. So it's pleasure to have you here, Dr. Satya. Over to you.
You hear me?
Yes, you are audible.
Just give me 1 second.
Sure, sure. Please take your time.
One of the don'ts is don't fiddle with the PowerPoint before you're going to share it. So here I am, and yeah. So the PowerPoint, is this visible now?
No, yeah, it is now. Yes.
Yes.
Yes, yes. Please go
Can you
ahead.
see it now? Full
Yes,
screen?
yes,
Okay, am I audible also?
yes, yes. Very rightly.
I'll proceed.
Yeah, thank you. Go ahead.
Basically, before we get into neuroimaging, we need to know the neuroanatomy well, and we need to guide the radiology technician to where is the lesion that we are looking for, what is the lesion. Once we get the films, we should look at the films carefully before we look at the report to confirm the findings. We should discuss the film with the radiologist, preferably a neuroradiologist, and if need be, we take a second opinion from another radiologist. Remember, the radiologist is not a clinician, so discuss the DD with the neurologist or neurosurgeon. This is something which I just coined. The contrast enhanced MRI does not lie. It is the observer who makes believe. So use the right sequences so that the interpretation comes out correct. Now, when we approach CT or MRI, we have to first decide which one we have to do. We have to decide which sequence do we need to do. We have to decide if contrast is needed or not needed, rather, because in most cases you need contrast. We have to decide if CT or Mrn angiography is needed or not along with it. And then we have also got to decide in our minds where is the lesion and what is the lesion, and then convey this to the radiologist. Also, how fast you need the imaging apart from the specific sequences. So now I'm just going to intersperse a few examples here. Now, when we see a patient with a skew deviation, we are suspecting a lesion obviously in the brainstem, and so we look like we write it on the request that you are looking for a brainstem lesion, and this is what we see, a dorsal midbrain in a contrast enhanced MRI on sagittal. If you have a clear-cut esotropia with a history of a maxillary sinus carcinoma, then obviously you're looking at the orbital apex, the extraocular muscles, and well, nobody will miss this on imaging. We have a visual fields with the right homonymous hemianopia, and then obviously you will tell the radiologist that you're looking for a lesion in the occipital area, which gives such a congruous homonymous defect. Now, if the imaging comes out normal, what do? You don't give up. You don't say, okay, the radiologist said there is nothing, this is normal, so just give it up. No. You can always ask for repeat imaging with thinner slices. You can ask for a higher magnification at the area of interest, especially if the clinical signs and symptoms are progressive. Definitely in that case. And you can ask for a discount. There's no harm in that. Recognize that the lack of an imaging abnormality does not rule out a pathology. So this is an example here. A girl who had persistent disc edema, and the first image showed nothing, second image showed nothing, but disc edema persisted and visual field defects kept on increasing, and repeat imaging of the orbit, fat suppressed. Looking at the retrobulbar area, we found this small, in just one slice, cysticercosis. So, okay, now indications, well, we all know the indications: unilateral or bilateral visual loss, efferent pupillary defects like anisocoria, corners of afferent pupillary defects with RAPD. This is one of those field defects, again, on exactly congruous, you could say, but it is affecting the middle as right homonymous, and it has a BCA infarct. Other indications we know clinically: proptosis, diplopia, lid abnormalities, oscillopsia, or nystagmus. So this is an example of a patient who had chronic proptosis with ophthalmoplegia and chemosis, and definitely we were suspecting an orbital apex lesion. So the MRI would be the better investigation because it shows soft tissue very well. And you can see the lesion here. And you have another case of orbital apex syndrome with a non-Hodgkin's lymphoma. So known case of non-Hodgkin's lymphoma with proptosis and maybe loss of vision in the left eye. You have a bilateral trigeminal schwannoma in a 30-year-old with progressive right eye ptosis and esotropia. And you can see that its color is so gray and matching the adjacent soft tissue that you need contrast, and you need to have several images to say what it is. You see this with contrast coronal image showing very bright lesions. So the other indications are Paplidema, then you have orbital trauma or headache or pain. There's one major difference between a CE CT scan and a CE MRI. The CE CT scan may just take 5 minutes to do, whereas a CE MRI will take 5 minutes. So in the emergency situation, you just do a CT scan immediately. Or if you have too many patients lined up for MRI, as it happened recently when we had so many rhino-orbital mucormycosis, that you do the plain CT scan because that is done faster. The radiologists, I must say, are inherently lazy. The reporting is done the next day. I don't know why. I never understood that. So don't wait for that. Call the radiologist on duty, meet him, discuss the findings, start the treatment, and do the referral. An emergent CT scan is required in such situations. You can see a traumatic blowout fracture clinically if you have a limitation of ocular movements. And you can see this case of a trauma with a a superior rectus hematoma. And another case where there was a bullets in the skull with so many of these artifacts on the skull. So all these require just a CT scan, immediate scan. And this is a case of a sudden proptosis in a patient with blood in the lymphangioma. Other situations are when there is acute severe headache, acute papilledema, acute visual loss, acute diplopia. You see post-meningioma, there is a hematoma there. A plain CT scan would show this very clearly. Are there any contraindications to contrast? Well, there's one. This is renal failure, or maybe an allergy to contrast. Contrast is definitely not required when a patient you're suspecting only an intracranial or intraorbital hemorrhage. It's a case of trauma. You just need to quickly do a CT scan, decide if there's a fracture or not, to be treated or not. This is two examples of intracranial hematoma, which are clearly seen on a plain CT scan. Traumatic limitation of abduction with zygomatic fracture. So you now decide whether you want to, reset this fracture or you want to wait for 6 weeks. Contrast, which is not required. You have a child with birth hypoxia. You have suspected hydrocephalus in a child. You have sinus disease. You just need a plain CT scan, but not the fungal type, as we saw recently. Then the thyroid eye disease, iodinated contrast may even worsen the thyroid disease. You just need to see thickening of extraocular muscles. All those examples are shown here. A child who has this one-sided hemiplegia, and you can see hemiatrophy. A plain MRI is done here. Then a patient with pseudopapilledema, where you are looking for optic dysdrusen calcification. So plain CT scan is enough. You have thyroid-related ophthalmopathy, where you see the thickening of the extraocular muscles, and plain CT scan is enough. Controversial slide. Don't fall in the trap of let's do a CT scan and see if need be, we will do an MRI after that. If you are suspecting a soft tissue lesion, please do an MRI. Let's do plain MRI, and if need be, we can get a contrast imaging. No. Do a contrast at the first shot. Let's admit the patient for neuroimaging. TPA will cover it. Why? TPA will not cover it. Let's send to that center. It is giving the maximum cut. Well, that is dishonesty. Just follow the radiologist's findings and DD and refer to the neurologist. No. CE MRI is the examination of choice. We've seen plenty of examples already, and I'm showing you a few other examples. This is multiple metastasis. This is an astrocytoma. You see the contrast, how beautifully it enlarges the astrocytoma. This is a huge pituitary macroadenoma, giant giant pituitary macroadenoma, where you can see there's contrast enhancement. Then this is an optic nerve and chiasm glioma, bilateral, with strong suspicion because child had visual loss and had also these skin lesions. So you can see the extent of the glioma so well. You have bilateral visual loss with multiple cerebral tuberculomas, including chiasmal involvement here, you can see. And then you have a patient with a left ophthalmoplegia and a Toulouse-Hunt syndrome. So all these soft tissue lesions are much better seen with MRI with contrast. So it is, there is a small risk of nephrogenic fibrosis. So always do creatinine and urea before ordering contrast MRI. Now, don't do orbital apex cavernous sinus. It definitely requires MRI orbit and brain. However, if patient is scared of the MRI and you are sure what the lesion is going to be, just go and do a CT scan, at least find out if there's a lesion there, and so that you can start some treatment. Patient has slightly elevated urea creatinine, don't avoid it. You can discuss with the nephrologist and use a certain dose of the contrast or a different contrast, which is safer. Have an understanding with the scan center, because I've been doing this all 20 years. There are patients who can't afford, MRIs are costly. So just go for a concession for the 5th patient. Also, they can do academic ultrasound, they can do a CT scan complimentary. You don't need to actually pay for it when they're doing an MRI. When I'll show you some indications. Ask for discounted rate for MRI when they do MRA, MRV, CTA. Ask for discounted rate for contrast MRI, head, face, and orbits, as in case of ROCM recently. So let us see. This is an example of ROCM. You see fungal sinusitis involving the orbital apex. You can see axial coronal images. And ask for a complementary CT scan, a plain CT scan. It doesn't cost them much, and they'll do it free for you. Okay, then. So what are the other indications of such CT with MRI? You have a craniopharyngioma in a 14-year-old with bilateral visual loss. So you can see the cystic nature of the craniopharyngioma, both on the CT and the MRI. You have an optic nerve sheath meningioma and you're looking for calcification on the CT scan, you can see the optic nerve calcification. And medial rectus cysticercosis in the orbit, and you can see in the CT scan calcified area. Tuberculoma of the optic chiasm. Again, you're looking for calcification, whether it is to rule out or to confirm, and then you look at the lesion carefully there in the MRI. And is there whether it's a cochlear implant, pacemaker, or metallic foreign body there, then yes, it becomes a contraindication relatively. Foreign body in the orbit, it should not move, so you will do a CT scan for that. These are the specific imaging sequences which I was talking about: fat suppression, FLAIR, GRE, DWI, PWCT. You also have CISS, and you have so many sequences. Fat suppression should be done as a routine. I don't think we need to tell them that. But for FLAIR, you need to tell them, because basically when you're looking for demyelination, then you should tell them that you need a FLAIR sequence. Fat suppression makes the lesion stand out very well, especially in the orbit. Then AV malformation of the left orbit here, you can see it better. FLAIR sequence shows these demyelinating lesions much better than a plain MRI or a routine T1, T2 weighted. I'm just getting over a few slides. GRE can show blood products. So you can see the image at the bottom, which is showing a lesion there, which would not have been detected if this thing was not done. Diffusion weighted imaging. Nowadays, this is done routinely and it comes along with the MRI, and at least because the neurologists are using it much more than us. It is looking for ischemic stroke in cases for us in homonymous hemianopia, cortical visual impairment, etc. You can see here the difference. The right side is, of course, a CT scan. It detected nothing. The left eye, an MRI with the DWI imaging is showing you the area of stroke. Then you have this 30-year-old SLE patient, and the typical lesion is a posterior reversible encephalopathy syndrome. And on the DWI imaging, it will be picked up before any other imaging of the MRI, any other slice of the brain. Then there's a diffusion perfusion mismatch, which is used, and this is also used for ischemic penumbra, how much of the area which is ischemic. And then coming to the last, MR and CT angiography, both are used routinely these days. These are the indications when you have a transient ischemic attack, homonymous hemianopia, strokes, isolated third nerve palsy or CCF. In the isolated third nerve palsy, already covered today in the first lecture. This is a patient who had a pupil involving third nerve palsy, and you can see how there's a suspected a pituitary adenoma. This is another example where third nerve palsy was a huge...
Sorry, Dr. Satya, sorry to interrupt you. Will it be possible to conclude? Because I think Dr. Rohit also have to leave for another session. And
Sure. I didn't hear this thing, warning.
I think you may have to conclude, Dr. Satya, because time is already up and we have
The
one
last
more.
slide.
Yeah.
Just the last slide.
Right.
So
Thank you.
ophthalmologist should communicate to the neuroradiologist the clinical findings, the suspected lesion location, the differential diagnosis, and the urgency of the imaging request to optimize the interpretation of the imaging studies. Thank you. That's all.
Thank you, Satya, for that comprehensive overview. For the lack of the time, I think we can take discussion later. And now we move to Dr. Rohit's talk, who is currently head of the Strabismus and Neuro-Ophthalmology Services at RP Center and also the Secretary for Indian Neuro-Ophthalmology Society. Over to you, sir.
Thank you, Swati. Am I audible and visible?
Yes, sir. Sure. Please go ahead.
Thank you. So I'll just be talking about optic neuritis and the changing paradigms that are happening with time, and I hope we can finish off in time. We know optic neuritis is inflammation of the optic nerve, which can present as papillitis or a retrobulbar neuritis. And occasionally they present with neuroretinitis, but essentially that is not considered to be a demyelinating. So we'll try and restrict ourselves to papillitis and retrobulbar neuritis, which are the most common presentations, which will typically present us with a uniocular involvement, predominantly in the young age group between 20 to 50 years, more likely to be in females. But the key factor we must remember, it is acute vision loss, mildly painful, the pain may increase on eye movements over hours to days. So the vision loss is over hours to days. It is not very sudden that it is just over a very short period of time. The vision loss may proceed for a few hours to days, and it may be very variable from very mild vision loss to complete vision loss. And the peak vision loss occurs within 2 weeks. It may remain stable for a week more and then starts improving. In unilateral cases, there will be an RAPD, and the fundus, as discussed, can be a papillitis or an absolutely normal RBN. If it's a typical optic neuritis, it's more likely to be due to multiple sclerosis, and now more likely possibilities being neuromyelitis optica. And of course, it does not rule out the possibility of infectious or other causes responsible for the optic neuritis. Optic neuritis with multiple sclerosis is important to know because optic neuritis may be the presenting feature in 50% of patients with multiple sclerosis, and of course may go on to involve maybe the presenting feature in 20% and may go on to involve almost 50% of MS patients. Atypical optic neuritis, on the other hand, is something that is like sudden loss. It is painless in age group which is not typical, like older patients, bilateral involvement, severe disc edema, or a lot of hemorrhages, progressive loss of vision more than 2 weeks, or it is not improving on treatment. A recurrent cause of vision loss also becomes atypical, or if it does not present with an RAPD in a unilateral case. So it's not that atypical may not be due to demyelination, but it's more likely that you should think of other causes like infective, compressive, or vascular. So typical presentations, think of isolated idiopathic or MS-related optic neuritis. Atypical presentations, start thinking of the other causes more than demyelinating, like NMO, MOG, autoimmune, and post-vaccination, or any other cause that may be responsible for the optic neuritis. The diagnosis essentially remains clinical, and it's based on the presentation, which is vision loss, the appearance of the disc, the presence of RAPD. Of course, if there is any doubt, you can do other investigations such as a VER, which may show an increased latency. But again, for diagnosis, usually for optic neuritis, and investigation is not required. We usually do a chest X-ray and electrolytes before we start IV methylprednisolone to be on the safer side. However, if there is an atypical presentation, we need to rule out infective inflammatory causes, and a whole lot of investigations then can be planned if there is a chance that it may not be possibly demyelinating. Currently, the role of MRI is become essential in any presentation of optic neuritis and would be considered mandatory in all patients. However, recurrent optic neuritis, atypical cases, patients with history of neurological problems, patients keen to know about long-term prognosis in children, it is absolutely mandatory. And as Dr. Satya right now talked about, the type of investigation and our instructions to the radiologist are very, very important. So if you think of MS, you need to ask for flare and contrast. So MRI with contrast becomes very essential. If you're thinking of atypical, it becomes very important because you don't want to miss a compressive lesion. So we know that in multiple sclerosis, role of MRI becomes extremely important because a very strong predictor for a subsequent development of multiple sclerosis, and any lesion on the MRI is 3 times more likely to develop multiple sclerosis over time than no lesion on MRI at the time of presentation. So, of course, from a treatment point of view, the ONTT actually gave us the clear guidelines that IV methylprednisolone should be given 1 gram a day for 3 days. Although now we sometimes give it to up to 5 days, especially if we suspect NMO spectrum disorder. We have initially were giving for many years dexamethasone because of its easier availability and its cost. But now, because again, methylprednisolone is easily available, it remains or becomes the first choice for intervention. Along with a neurologist, if there is a major risk of multiple sclerosis or there is a high suspicion that the patient may go on to develop MS, there is a major role to discuss disease modifying agents which may be started to reduce the relapses of optic neuritis and subsequent multiple sclerosis over a period of time. In India, we have seen over time there has been it was very different from what we had observed in ONTT, and we had higher incidence of papillitis, poorer visual outcomes, bilateral involvement, as well as the outcomes overall were less for visual outcome, whereas the association for MS was not as much as seen in the ONTT. And this is a comparison with other Asian studies where similar features were seen. So over time, we have realized that MS in Asia may have a higher percentage of NMO, which is very important. So NMO or neuromyelitis optica has been seen in up to 10% of patients with a presentation of optic neuritis or transverse myelitis. So it's very important for us to consider NMO and work towards it. The importance in NMO is, of course, the NMO serum levels for antibodies of the NMO and the MOG, but even MRI in the beginning can give us a good idea about the possibility of developing NMO or MOG. So again, the role of MRI in understanding or predicting NMO is becoming increasingly important. For NMO, again, the aim is to start off with IV methylprednisolone, often especially as we wait for the NMO test to come. But if the outcomes are poorer, or if it's a strongly positive NMO, you consider for plasma exchange also along with the neurologist. Over time, they would require immunosuppressive therapy and not disease-modifying agents which are given for MS. MOG is another association that we can see, and MOG-associated optic neuritis is also being picked up increasingly, especially after this current COVID outbreak. As I said, the MRI is classically different in these 3 conditions, and you can see the involvement of larger areas, chiasmal involvement in NMO as compared to a small segment in multiple sclerosis. So the MRI at the very initiation becomes key. So optic neuritis, if there are typical features, you give IV methylprednisolone, see for improvement and follow-up. Does not improve, or there are atypical features to start up with, do a comprehensive workup, may require NMO or MOG involved antibody test, and do a tailored approach based on it. You may require long-term therapy with interferons in MS and immunosuppressives in MOG and NMO. And basically, to conclude, optic neuritis can be isolated or be a part of multiple sclerosis. If there are atypical features, investigate for cause. Baseline MRI is now essential. IV methylprednisolone is important and no more an option. And disease-modifying agents may reduce space in multiple sclerosis, contraindicated in NMO. Thank you.
Thank you, sir. Thank you for covering that update in optic neuritis. It is becoming more and more challenging now because of this overlap of clinical features and development of new entities every day. So thank you. I think we have managed to conclude the session at least 1 minute before the time.